Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Austin Howald, a licensed clinical social worker who serves as the Director of Integrated Community Services at Chestnut Health Systems. His work has targeted the intersection of mental health, housing insecurity, and social drivers of health in central Illinois. Austin, hey, how are you?
Good. I'm doing great. How are you today?
I'm doing well. We're recording this on a Monday, and you told me that your Monday morning is getting off to a good start. That usually augurs well for a good week. I hope that that's sort of contagious, and I can get some of that, Austin. In any case, yes. In any case, thanks so much for joining me today. I've been looking forward to speaking with you. So, just to begin, how did you get into this work?
Yeah, that's a good question. Looking at some of the content that you guys have on the Catalyst site, I know that peers have been a point of focus, and I actually consider myself a peer. I had a bit of a academic or career change in my early 20s. I was focused on a science and math career and kind of had a pivot into the helping fields. So I had my start here at Chestnut Health Systems as an intern, and I worked at a local emergency shelter. So a lot of work with the unhoused population locally and substance use population. So that's where I got my start.
Were you able, or have you been able to bring some of this computer math background into your work?
I think so. As clinicians, academically, we don't have a whole lot of, accounting or finance or math classical training. So I try to lean on that in an administrative capacity and try to be really thoughtful about, outcomes from a quantitative perspective
Mm.
and things like that. So yeah, I use it from time to time.
I know that an important part of your background is the work you did, Salvation Army, their emergency shelter. And when we spoke, you talked about how it sort of informed and inspired the work you've done since. Can you just speak to that a little bit?
Yeah, absolutely. So there's two emergency shelters locally here in Bloomington, Normal, Illinois, which is where Chestnut's central region's operations are located. Those two shelters have a combined capacity of about, I'd say, 80 to 100 permanent fixed beds for residents that would otherwise be street homeless. And I worked in the shelter that had a dormitory setting for men and women. So there were roughly 20 women and 40 male dorm bed spaces. And individuals could be there from realistically a stated timeline of 2 to 4 months. However, given the complexity of housing in the area, we have an inventory shortage of affordable apartments and housing options, and the intersection of substance use and mental health concerns. Folks are often there a fair bit longer. And this shelter is one that's considered a low barrier shelter. So the only items that an individual would need to qualify for assistance would be a receipt that they bring from the local police department illustrating that they didn't have active warrants, and a brief background check for registry status, and just the individual stating that they were homeless. So
Mhm.
if they have a severe mental health concern, some kind of illness, severe substance use concern, financial issues, employment, none of it. If they needed a place to stay, then we were going to help them.
So your work came at a time where you have finite capacity, but also very limited affordable housing. How did you manage to creatively solve that problem?
Yeah, that's a great question. So I mentioned the permanent fixed bed space. We know that the winters in Illinois can be a bit inhospitable. And one of the shelters, the shelter that I actually worked for, expanded bed space every October. So we'd see the temperatures pretty consistently drop during the second half of October, and an additional 100%, I suppose, of bed space capacity would open up each year. So locally, we could serve emergent needs due to weather, but the shelters, other social service providers, Chestnut, different agencies, the hospitals are all engaged in what's called a continuum of care. That's a federally federal HUD designation for like a local organization of different groups that work together on housing needs. So we would all come together and look at different solutions, ensure that we were trying to meet the need where it was. And at times that includes outreach efforts. There's a smaller subset of the population that is permanently outside, either by choice or certain barriers that can't be sort of navigated on the shelter space side of things. And those individuals still receive help from different agencies through outreach efforts with Weeks and Plan.
What was the one major takeaway from that experience, or something that you learned, or something that challenged some preconceived idea in your interaction with this population or this type of population?
I think we have a national conversation around homelessness and the intersection of mental health and substance use. And I think if I were going to describe it, I'd say that
By the
there's
way,
a
let me ask you a question, and not to be picky.
no,
You talk about homeless. Is has the term of art changed? We're talking about the unhoused. Is that an important distinction to make?
I think it can be. I think it depends on, I guess I'll just clarify. When I'm referring to an individual, I'll refer to them as being unhoused or however they'd ask that I refer to them. When I speak about the overall issue, I tend to rely
I
on
see.
this
I see. Okay.
pertaining to an individual. So if we think about issues related to folks who are unhoused, I think might be a more fair way to say it.
Okay.
It often becomes,
You know what? I don't mean to interject anything that may hint even at sort of, political conversation. It's really just for purposes of clarity, because I hear these two terms and they sort of jostle up against each other, and I'm sh not sure how they should be applied. So thank you.
yeah, that absolutely makes sense. I think it's a great question. Um, so I think we have a national conversation that qualifies someone's experience as being unhoused as almost like a moral conversation.
Mhm.
And the two things that really stood out to me is that a lot of the folks that we saw enter the shelter space were, and I'm going to use the word outside of any sort of like judgment, but normal people who simply had one thing go wrong, one
Mhm.
lost paycheck, one medical event, one
Right.
inch away from financial insolvency. And the reality is that's not a moral discussion. And then when you think about other folks that have a really high degree of severity from a mental health perspective, that again is not a moral discussion. And I think we owe it to our unhoused neighbors to try and support them the best way that we can.
So was that the major lesson you took away from this, to sort of decouple the morality play that often attaches to this, just talk about different people have different problems that lead them to this particular place?
Yeah, exactly. I mean, it could be profound mental health. We think about psychotic illnesses like schizophrenia or schizoaffective disorder, bipolar, it could
Mhm.
be something to that effect, or
Right,
be someone who just lost their job due to layoffs.
right. Yeah, no, it's incredible, how thin that margin can be. So, which brings us to really what I want to talk about today, the Medicaid Innovation Collaborative, or MIC. First, describe this concept and how it works.
Certainly. So the MIC is it's a collaborative. It is a joint effort in which OSF, which is a large hospital group throughout Illinois, and I believe some other states, approached four FQHCs. Those are federally qualified health centers, of which Chestnut is one, uh, in pursuit of obtaining a state funding source to innovate the lives of individuals in Illinois that are recipients of Medicaid. And there's a number of different programs. It was an open book in terms of implementation and development. Each of the FQHCs or FQs, as I'll refer to them, chose different sort of sub-programs to
Mhm.
deliver that larger sort of mission. Chestnut Health Systems landed on a food pharmacy, which is it's a program that provides fresh, nutritious, healthy food alternatives to individuals locally in a food desert that may otherwise not be able to acquire that food, either financially or through the realities of like transportation and the food desert issue. And then we have a community health worker program, which sees a peer professional enter into spaces locally to help individuals connect to a medical home. And then finally, we launched a Medicaid-oriented dental practice to support a population of people that otherwise don't receive much in the way of dental care through Medicaid traditionally.
So these three components is what Chestnut contributes to the collective, or excuse me, the collaborative.
Correct.
I see.
One of the other broad takeaways is that part of the proposal is that as a hospital group, OSF has developed a really unique suite of remote patient monitoring programs. They refer to it as on-call. It has 5 unique sub-programs within the on-call umbrella. There's one for behavioral health, one for maternal wellness, one for low acuity health issues, moderate acuity health issues, and then high acuity comorbid chronic health issues. And these are open to the OSF patient population, but our proposal as Chestnut with the programs that I mentioned that we're operating came with an exchange in which we are able to engage our patients that may have nothing to do with OSF typically in those on-call products and provide them with a level of care that a Medicaid patient may otherwise not experience.
Right,
So
right. Right. I want to get into several specific examples, and I know there were quite a few, but there were 2 or 3 that I found just looking at them that seem particularly compelling. Before we get to that, I just want to ask you a question. You say that, you know, your charge, this whole thing is about innovating in this space. What does innovating mean? I mean, are there metrics? How is that judged that this program actually is quote unquote quantitatively innovating or even qualitatively innovating in the space?
Yeah, great question. Well, I have a very long list of metrics that I submit each month. But those quantitative metrics are basically outcome and demographic data. So one of the lenses through which the MIC collective views our patients is the social drivers of health. Those are a measurement of non-health or health adjacent factors in an individual's life that actually have a great degree of impact in their health.
But I'm sorry to interrupt, and I don't want to get into this hair splitting, but you said the social, what do you say, definers of health, use the term, is that again, same as social determinants of health? There are some people who are going to be listening to these conversations, and sometimes I make the point that, we're so used to speaking using a certain language because we take it for granted we're speaking to like-minded people who understand these issues. But sometimes, you use some people may have heard social determinants of health, hear something else, just throws them off a little bit. So I just want to sort of level set that.
Yeah, it's the same thing. So social determinants versus social drivers. Social drivers.
Drivers.
My understanding is that social determinants was the original language used to describe that concept. I think the industry's made a move towards drivers with respect to the idea that a determinant determines, it's deterministic in nature. That I will be unhealthy, as an
Right.
example, as opposed to being unhoused might drive my health towards a negative outcome.
Might be complicit in the outcome.
Yeah.
Right. Okay. No, I just wanted to establish that also for my own benefit. Okay, so these specific examples, again, we initially spoke last week about this, we were going through, and there are numerous examples of the MIC collaborative, the work you all are doing. So we were talking about several in particular that seems to me to just sort of leap out. And one is the aforementioned Salvation Army. So describe what you're doing with the Salvation Army.
Yeah. So we knew in designing this project in the specific community health worker project that we wanted to position these staff members to connect people to medical homes in spaces that were efficient. So we know that in McLean County, there are roughly 30 to 40,000 Medicaid lives. And one of those outcomes that you had asked about that really determine our success as a collaborative is our ability to engage with those Medicaid lives and ensure that they have a regular medical. Once an individual is placed on the Medicaid roll, there's nothing that really ensures that they actually engage in healthcare. Maybe they are at an emergency department once, or maybe they go to a prompt care, or they see the primary care provider one time, and then they kind of fall off the engagement drives that. One of our metrics for success is getting those folks connected to a regular medical home. So we knew that we wanted to be efficient in that regard. And through the development process in the first 6 months, we started in calendar year 2022. I think it was in January when we signed the MIC agreement. So by June, we had developed an implementation model that placed our community health workers in spaces with a high degree of overlap with the Medicaid population. So
Uh-huh.
is a simple nod to that concept. So the idea is that a community health worker enters that space and works with the existing social service staff, like case managers, housing navigators, et cetera. And when those individuals start to work with a participant who has health needs that may even eclipse their immediate housing needs, they hand that person via a warm handoff to our community health worker. And the community health worker completes an SDOH, social determinants or drivers of health assessment to interpret the individual's needs, connects them to a medical home, and follows them longitudinally to reduce the barriers that prevent them in the SDOH realm, prevent them from engaging in regular preventative health care. And the idea is that over time, these individuals' lives and their health outcomes would improve.
Going through some of these other examples, the EMS response network, what did that look like?
Yeah, that's in its infancy. It's really exciting. I like talking about it. Around this time or late spring last year, we had met with a representative from one of the local fire departments. It was their outreach officer, and we were talking about ways that Chestnut and the fire department could collaborate to support the population. And where we landed was recognition from this is language that the fire department had used. Recognition of the fact that many of the calls that they respond to are low acuity calls. We know that they have fire engines, they're have fires, save lives, emergency help needs, etc. But many times they'll get calls for folks who have fallen or cannot get up from a certain space, or like a bed or a chair, or have some mental health concern that maybe is severe from a mental health perspective, but maybe not actually extremely severe from like a health perspective. And so they're able to locate high density spaces throughout the area where they respond to a high volume of low acuity calls. And they end up with what we like to call friendly faces, people that they see more often than not. And so the discussion yielded a co-location model where if an individual was amenable following one of these emergency calls, amenable to working with a community health worker, the fire department would hand them off to our staff to engage them and promote more preventative care. So as an example, someone who might be struggling with obesity and is struggling with hygiene or mobility issues that generates anywhere from 3, 5, 10 calls to EMS and the fire department in 1 year would instead start working with a community health worker who gets them engaged in something like our food pharmacy, where there's healthy food alternatives, regular medical home engagement that may not even be Chestnut, and seeing a primary care doctor to help resolve those mobility, hygiene, and obesity issues.
Yeah, by the way, again, for some reason in our conversation, terminology seems to be sort of a sub-theme. Community health worker. Is a community health worker sort of synonymous, or is it implicit that such a person is also a quote unquote peer?
I wouldn't say it's one-to-one, but our intent in the program is to leverage peers. And traditionally, if you look at the definition of a community health worker, I would think that your suggestion is accurate, that they are one-to-one. Community health workers are not a new concept. When we started this program, I did some brief reading and found that, they're referenced even, 100, 200 years ago in rural spaces throughout Europe where a practicing physician would leave. And with transit time being as long as it was, if that individual was gone for weeks or months, they'd have to elect another community member to be a community health worker. So that
Yeah.
individual would literally be a peer. And today, we select individuals or attempt to select individuals that look, sound, and feel like the population that they're serving.
Mm.
So an individual placed at one of the fixed co-locations at an emergency shelter would be someone that has some degree of experience or is maybe adjacent to the topic of being unhoused and has some of
Right.
that support that they can find.
There's another example. We didn't get into in any great depth when we first spoke, and it's where you collaborate with a competitor. Describe that collaboration.
Yeah. So we are not the only Medicaid-oriented healthcare provider in the local space. There's two large hospital systems, ourselves, and then another clinic. And ourselves and we in this clinic don't view each other as competitors per se, but from an outside perspective, we share the same market. So if someone was inclined, it wouldn't be unfair to make that suggestion. But instead, we choose to view our work together as a spectrum and degrees of severity in someone's needs and their ability to engage in, the medical practice. So we actually have a community health worker in their space. They do not have a permanent case manager. So we approached them about adding a CHW to their space to serve their population. And we move patients from one building to the other, one organization to the other, depending on the patient's needs and their self-determinism. So if a patient feels that they would have better care with Chestnut, then we will pull them in our direction. If they want to stay with this other clinic, we'll push them that way. But we have effectively partnered with that organization to provide them what amounts to a free case manager and community health worker to support their population.
Yeah, neat. Austin, closing thoughts.
Yeah, closing thoughts. I think it's really important given the national conversation on efficiency and being a good steward of finances and federal and state funding that we're extremely efficient and targeted in our efforts. And that's been baked into every element of program design with our co-location model, the spaces that we enter into. And even more so now as we're rounding out entry into the last year and a half of this project. One of my colleagues and I who work on this program, we're extremely focused on making the biggest impact on the individuals internally that need it the most and focusing on individuals that would be considered high utilizers. So we're really trying to help the people that use healthcare the most and bear the greatest weight on the local healthcare system and getting them more engaged
Mm.
and where they have better health outcomes.
It's almost an ethos because what you're talking about is shared by your Chestnut Lighthouse colleagues in all the endeavors, all of the projects, all of the initiatives. This idea that we need to promote efficiencies. It's all about evidence and being evidence-based, about outcomes, about discipline. It's not just a model in what you are doing with the collaboratives, but across the board. Anyway, thanks so much. Today I spoke with Austin Howald, a licensed clinical social worker who serves as Director of Integrated Community Services at Chestnut Health Systems. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.